Good afternoon, all. Uh, please welcome please welcome Professor D. Prabhakaran,
No, I think I put it.
eminent cardiologist and epidemiologist from the Public Health Foundation of India, and he's the Vice President, Research and Policy for Public Health Foundation of India, as well as Executive Director for the Center for Chronic Disease Control. Now, the Center for Chronic Disease Control is a joint initiative of four really eminent and leading institutions: PHFI India, London School of Hygiene and Tropical Medicine, AIMS New Delhi, and Emory University. Now, what is magnificent about his work is the holistic approach. So, his work focuses on understanding the causes of increased propensity of cardiovascular diseases among Indians, as well as to develop solutions for these diseases through translational research and human resource development. So, we see that real translation happening from treating an individual to improving the health of a whole population. He is a fellow of the Royal College of Physicians, United Kingdom, fellow of the National Academy of Sciences in our country, and an adjunct professor at the Emory University. He is a member of the Executive Council of the International Society of Hypertension and chair of the International Society of CVD Epidemiology and Prevention. So please welcome Professor Prabhakaran for his CBR Popular lecture today.
So good evening to everyone, and thank you for that very kind and longish introduction. How did this title come about? My mentor, Dr. Reddy, he likes to say that science is reductionist in content but holistic in context. So I thought, why not elaborate on that theme and give this talk? So I'm going to talk on two themes. The first is the reductionist theme of trying to identify the causes and mechanisms of high propensity of cardiovascular disease in Indians. The second is having identified what can we do about it. I mean, we know what the reasons are, but how do we address and reduce the burden? So these are the two aspects which I'm going to talk about. So in terms of outline, I'm going to briefly talk about cardiovascular disease in Indians and what evidence is needed for cardiovascular disease control, translation and scale up, and addressing the challenge of new and emerging areas. Now, the first time we spoke about cardiovascular disease in Indians was 59 years back. A scientist by name Dhanraj and his colleagues at Singapore did an autopsy study comparing Indians and Chinese. So you can see in this table that Indian males had a very high propensity to die because of coronary heart disease. In fact, it was 2 times higher in Indian males aged between 30 to 39 years as compared to the Chinese males. And in fact, if you look at the age-specific mortality between 40 to 49 years, it was almost 5 times higher. So clearly there was something that was happening, that coronary artery disease, particularly heart attacks, were much higher amongst Indians as compared to the Chinese ethnicity. So people thought this may be a one-off thing, but there were lots of studies across the world. There were quite a few studies between the 1980s and 2000. So between 80 and 2000, there were nearly around 10 studies emanating from UK, Tanzania, Uganda, Jamaica, and several other places, which suggested that there was something that was different that was happening, and that could be the reason for cardiovascular diseases in Indians. One of the theories was conventional risk factors were not important for cardiovascular disease in Indians because people felt it was related to insulin resistance. They felt that it was because of something else like homocysteine, Lp(a), several other factors, and they felt that the conventional risk factors such as smoking, hypertension were not very important. So why did this happen? We compiled all the studies that were conducted for the last 25, 30 years and classified them into 3 groups. One group of studies looked at migrant Indians who had settled abroad as compared to Indians living within India. The second group was a group of migrant Indians who were residing, for example, in London, were compared to the local population. The third was within country migration, that is people who migrate from urban to rural locations. When you look at migrants, the first group of migrant studies where we are comparing migrant Indians to the local population, it appeared that unconventional risk factors were important because they were living within the same environment but had a different gene pool. So it appeared that the environmental factors were nullifying, and therefore unconventional risk factors came to the fore. But when you look at a comparison of Indians living abroad or South Asians living abroad as compared to our local population, it appears that the conventional risk factors are important because the environments are different. So when the environments are different, your diet is different, your physical activity is different, the lifestyle is different, and therefore lifestyle trumps. And similarly, a comparison of rural-urban migrants again suggests that there is a high prevalence of conventional risk factors amongst people who migrate to urban locations from rural locations. So clearly, it emerges that it appears to be smoking, dyslipidemia, diabetes, and several others. So this is just to summarize what could be the mechanism. So when we compare migrants with other ethnic groups living in the same environment but having a different gene pool, it appears that non-conventional risk factors become important. But when you do urban-rural comparisons and migrant-non-migrant comparisons, these are people having the same gene pool but living in different environments, and here conventional risk factors appear to be important. We needed proof, and this came by the Interheart study, which was one of the largest studies conducted in the world. It was conducted in 52 countries, had around 14,000 incidents, that means people who had heart attack for the first time, and they compared against 14,000 controls. And it emerges that 90% of the risk were due to simple risk factors such as smoking, bad lipids, high blood pressure, diabetes, abdominal obesity, psychosocial factors, and fruits and vegetables were protective. Physical inactivity again increased the risk, and alcohol at moderate consumption in most population except South Asians appeared to be protective. So this gave a big message, because before the study came, people thought that more than 50% of the risk cannot be explained by the conventional risk factors, and this said we can explain it by 90%. So people criticized the study. They said this is a case control study, you cannot come up with these conclusions, you need cohort studies, and several other criticisms came up. But subsequently it has been shown that nearly 80% of the risk can be easily explained by these risk factors. Now the question is, we know what it is. Should we look beyond this? Should we do something about this? Because we know this, why do we need to do more research? That's a question which a lot of people ask. So I thought there are several reasons why we should ask. A, when we look at different ethnicities, the threshold at which some of these risk factors operate are different. For example, I'm going to show that example of obesity and diabetes. It's very different in the US population as compared to Indian population. So we need to look at it in a different manner. The second is, when you look at the type of heart attacks, Indians have a very severe type of heart attack where there's a complete blockage of the artery, which we call as ST elevation myocardial infarction, as compared to Western population, which has a partial occlusion. And so is the thrombotic load high in Indians? Is there a genetic basis for that thrombotic load? That's a question which we could ask. Second is, when from Chennai, Dr. Mohan and group report that among their diabetic population, the BMI of less than 18.5, which is considered as undernourishment, is to the tune of 30%. Nearly a third of the diabetics of Dr. Mohan's group is lean. So how do we explain this paradox? Then there are differences in lipids, which I'll allude to, differences in body fat, then there are dietary issues, and there are several new and emerging areas such as air pollution. So we need to understand mechanisms. One important reason as a clinician, for a clinician, it is important for me because we need to get guidelines, and these guidelines can come only from epidemiological data. You would be very surprised that we are treating Indians for hypertension and diabetes based on Western guidelines. So we need our own data, and that's the reason why we have to study mechanisms. And therefore we were interested in establishing a cohort, and this cohort was established in 3 locations. This was a study funded by the National Heart, Lung and Blood Institute of the US. So it was established in Delhi, Chennai and Karachi. In addition, we established a large rural cohort in Solan in Himachal Pradesh, and we have 2 cohorts in 2 transitioning cities, in Vizag and Sonipat. What we have done here is we have recruited people above the age of 20 years, included both the genders, and we stratified them based on residence and location so that we get a representative population. We collected several demographic, behavioral, anthropometric, and blood measurements, and this became a huge platform for young investigators to do their postdoc or PhDs, and several interesting things have come out. In addition, we have almost 600,000 aliquots of different components of blood, urine, saliva in long-term storage. We have extracted DNA for nearly 8,000 individuals. So this has a potential to give Framingham-like data because we are waiting for mortality, enough number of mortality and events to accrue. Currently it's around 400, but we require at least 750 to have a reasonable power, so we're waiting for that. Here we can understand social determinants, and these biorepositories also can help in understanding the mechanisms of disease. I'll skip this slide because I already spoke. Now, if I ask in this audience, what do you think is the cause of diabetes? Most of you would say that it is overweight and obesity. Because of lifestyle changes that have happened, because of globalization, urbanization, people have changed their lifestyle, they become more sedentary, they eat all nonsensical stuff and put on weight, and that increases, leads to hyperinsulinemia, ultimately leading to insulin resistance and increasing the risk for diabetes and impaired glucose tolerance. This is the conventional view. You ask anybody, this is what they would say. But let's do a comparison of the United States population, Chinese population, and Japanese population. These are real data. These are data from the country profile of the World Health Organization and the International Diabetes Federation. Look at overweight and obesity as defined by BMI greater than 25. In the USA, it's almost 2/3 of the population. In China, it's nearly 1/3 of the population. In India, it was only 13%. You don't really find that extremely obese people. You find people who are thinner but have this abdominal obesity, but you don't really find that extremely obese people. But look at the diabetes prevalence. It's 9% in China, 9% in US, and 9% in India. How do we explain this? Because we have been always saying that this is the relationship between, there's a huge relationship between obesity and diabetes. How do we explain this? Second is, as we saw in the earlier comparisons of migrant, non-migrants, we also need to look at people who are living within the same location. And so my colleague Dr. Venkat Narayan and his PhD student Oza Frank Reena looked at this different ethnicities who are living within the United States. And as you can see here, the highest prevalence of diabetes was present in people of European origin when they were obese. And that proportion was very similar to people who had a normal weight amongst Indians, clearly suggesting the thresholds at which Indians develop diabetes is much, much lower. Is it a threshold effect or is it something else is what we need to answer. So the questions that we posed were, what are the potential reasons for this heterogeneity in the epidemiology and association of diabetes amongst these different ethnicities? The question is, do we have a reduced beta cell mass? As you know, beta cells are important for insulin secretion. Do we have them? Is the mass reduced? The second is it altered body composition? And I will show you from example from Dr. Yajnik and colleagues who have shown that even as kids, even as neonates, the body fat content is higher in the Indian neonates as compared to their Western counterparts. And this has been shown in several studies that Indians have a higher proportion of body fat. Poor maternal and early child nutrition is clearly linked to higher risk for diabetes. Then we have high carbohydrate diet, lipotoxicity, microbiomes, endocrine disruption due to air pollution and organic pollutants, hepatic infections leading to non-alcoholic fatty liver disease, and of course there could be unknown causes. But let's explore only one of these, the reduced beta cell mass, and see how we can explain. Many of you must have heard about Pima Indians. Pima Indians are the original American, even before the white man came. There were these original inhabitants, the so-called aboriginals, the equivalent of aboriginals in the US. So they lived in a place called near the Gila River, near Arizona. They were Central American migrants who migrated to the United States somewhere around the 13th, 14th century. So Peter Bennett, NIH investigator, who was studying rheumatoid arthritis, because rheumatoid arthritis was very high in this population. And then he collected blood samples and looked at their whether they had diabetes, and to his utter surprise found that they had the highest prevalence of diabetes in the world. And then they looked at all the other things and they found that they were extremely obese, and this concept of obesity related to diabetes came from the Pima Indian study. So we compared Pima Indians to Asian Indians, Indians who were living in Chennai in our population. The prevalence of diabetes amongst Pima Indian was very high, 50% by the age of 55 years. In Asian Indians in Chennai, very similar, very high, 50% by age 55 years. But look at the obesity profile. The Pima Indians were very obese. Their mean BMI was 33.7, mean waist circumference was 108, very big. But the Chennai Indians were relatively thinner, mean BMI of 25.7, mean waist circumference of 83.1. Glucose profile, the Pima Indians had a higher mean 2-hour plasma glucose. Asian Indians had a higher mean fasting glucose. If you talk to any clinicians who manage diabetes in Indians, they find it very extremely difficult to control the fasting blood glucose, and this is reflected here. Now, what does this higher mean 2-hour plasma glucose mean? It means that there is a very high degree of insulin resistance. They produce a lot of insulin, but the insulin is not effective. It doesn't push the glucose into the muscles. So, high degree of insulin resistance. And this again is reflected by the type of prediabetes they have, which is impaired glucose tolerance. So, they have 2 to 4.5 times more insulin, and the insulin resistance is higher than the Asian Indian across all BMIs. Whereas in the Asian Indians, it is what we call as impaired fasting glucose, and their insulin, the Asian Indian insulin, is half to 1/3 of the insulin secretion found in the Pima Indians, which suggests that there is some degree of dysfunction in the beta cell, and this has been studied by what is called as disposition index in 2 or 3 studies. So, our hypothesis has been that there are 2 types of beta cells. Because we have spoken about types of diabetes, most people talk about 2 types of diabetes, type 1 and type 2. Type 1 is total lack of insulin, and type 2 is faulty insulin action. But I think there is a new concept that could come up maybe in the next few years. We may have a type 3 diabetes, and that's why we are coming to this narrow beta cell capacity and wide beta cell capacity. When you have narrow beta cell capacity, in the basal metabolic state, the fasting glucose levels are high. Slight or moderate demands for insulin lead to strained beta cells and acceleration of impaired early phase insulin secretion, and the dominant form of prediabetes is impaired fasting glucose. And these people rapidly convert, that's another problem in Indians. When you develop prediabetes, you rapidly convert to diabetes within a matter of 3-4 years. Whereas when you look at the wide beta cell capacity, populations with wide beta cell capacity, in the basal metabolic state, they have a low fasting glucose. Slight or moderate demands for insulin are managed efficiently over time through compensatory insulin secretion. And the dominant form of prediabetes is impaired glucose tolerance, and there is a slower conversion until obesity and insulin resistance are great. So, clearly there are 2 types of diabetes, and that's how this is the reductionist paradigm, where we have gone down to the basics of science and understood the mechanisms. Now, why this happens is the next question that we have to see. So, this is another thing which we all know. If you redraw the map of India based on low birth weight and under 5 nutrition, it will occupy more than half of the world map. Similarly, if you draw the map of diabetes, it will again occupy nearly half of the world. So, how do we explain this paradox of ubiquitous low birth weight and childhood undernutrition and the high burden of diabetes? So, for this, if we invoke the Barker's hypothesis, David Barker from Southampton did a study in the early 90s and showed that children with low birth weight who were born in the 1900s and 1910s and 1920s with low birth weight had a higher risk of developing diabetes and dying due to cardiovascular disease, and hence it is called as Barker's hypothesis. So, clearly if you study pregnant women and if you study fetal life, you will understand much more things than what we are doing now. So, there are other issues during development. Now, there are several studies to support this hypothesis. There are almost 100 studies, 100 publications from many countries including in India, which says that low birth weight kids have higher amount adiposity, hypertension, coronary artery disease, type 2 diabetes and stroke. The question is it only a phenotypic change that is occurring because of the fetal adverse environment, or are there epigenetic changes that happen? And there are some evidences to suggest that it could be epigenetic changes. which actually results in poor muscle development, lower levels of vitamin D, and so many other causes that we know. And these are areas of intense investigation. There are a lot of people working on this. So we will know about this in the next few years or so. We have another cohort in Delhi, and I am part of this cohort called the New Delhi Birth Cohort. These were children who were born between the years 1969 to 1972. And the cohort was assembled to look at actually birth weight, to look at nourishment. Are the kids undernourished? That was the whole reason to look at. So they were well studied. The weight and length were measured at birth. Weight and height were measured 6 monthly up to age 21 years. I joined this cohort in 1996, and we retraced the cohort back and collected data of around 1,500 individuals. We did anthropometry, oral glucose tolerance, blood pressure, and fasting lipids. Now, this was published in New England Journal of Medicine. It is very, very revealing. These are people who go on to develop diabetes, and these are people who have the ideal blood sugar level. When you look at this, people who went on to develop diabetes had a lower birth weight. Their weight decreased till 2 years, and then their weight started increasing, suggesting the importance of childhood obesity. But these were really not obese people. Their weight was higher than the cohort mean. But when you look at the kids who had the people who had the ideal blood glucose, they started off with a higher birth weight. Their weight increased till 2 years, and their weight started declining. There are two messages here. Whatever the changes that happen in the first 2 years are very important. And secondly, the changes as the children grow, and if the weight keeps on increasing, their weight at 12 years had the best correlation for predicting diabetes. So clearly saying that we need to do something to children, because that's a point when we can intervene. So the highest prevalence of impaired glucose tolerance and diabetes were among subjects who were in the lowest third of the group with respect to BMI at 2 years, and the highest at the age of 12 years. The third hypothesis that's come up from Dr. Yajnik's group is the thin fat newborn. If you look at this kid, the kid is very thin. This is a European kid, but look at the amount of fat, intra-abdominal, intraperitoneal fat, pretty high. So the kids in India, even though they are born with low birth weight, they have a higher fat content. And this he elegantly published this. This was a comparison. It was called the Yui Paradox. This is Professor Yudkin from University College London, Professor Yajnik. Interestingly, they had the same BMI 22.3, but look at their body fat. Yajnik has 21% body fat and Yudkin has 9% fat. They published calling this as Yui Paradox. But I mean, we may laugh at this because this is one single individual comparison, but there have been several studies to show that body fat levels are higher amongst Indians. So understanding diabetes in India, there are various research questions we really require to get into the depth and understand. One is association of persistent organic pollutants with incident diabetes. We just completed recruiting these people, and we are looking at the 10 organic pollutants in a nested case control design. We are studying air pollution and diabetes. We are also studying diabetes and non-alcoholic fatty liver disease. I spoke about beta cell function. So clearly there are many, many things which we need to look at in terms of depth. So this is the reductionist philosophy that is needed to understand a disease. Now once we understand the disease, we need to move further. But before that, let me look at the lipids, the differences in lipids. All of us know that LDL cholesterol is bad. High degree of LDL cholesterol increases the risk of coronary artery disease. But let's look at what happens to Indians. For any given level of LDL cholesterol or total to LDL cholesterol ratio, the total cholesterol to HDL cholesterol is the good cholesterol, is higher. And there are different types of LDL. There are 3 different types of LDL. We have large particles, intermediate particles, and small particles. And Indians seem to have a very high fraction of small dense LDL. And it's associated with high levels of triglyceride and a lipoprotein particle called ApoB. I'll show you what that is. So this is an LDL particle. The atherogenicity or the increased risk for atherosclerosis is provided by these surface particles called apolipoproteins. Now when we measure LDL cholesterol, we measure the mass of this. But when we measure ApoB, we measure the number of particles. If you have the smaller type of LDL cholesterol as we Indians have, we have more of these particles. So it is much more atherogenic than the usual. So is this all theory? In the Interheart study, the South Asian cases had a very high proportion of ApoB to ApoA1 as compared to other countries, whereas other risk factors were somewhat similar, except hypertension. Hypertension was self-reported, given the fact that Indians don't report, the self-report is low. So this explains. But look at this. This was actually measured, and it was hugely different between Indians and other countries. We also have, from our cohort, we made a comparison with the US population using the enhanced data. And you can look at this here. LDL cholesterol is higher in the US population. It's lower in the Indian population. But ApoB is higher in the Indian population as compared to the US population, clearly suggesting that we require a different biomarker and not simply follow what the US has been telling us. And the interesting point is the ApoB is linked to other metabolic parameters such as triglycerides. Triglycerides go with diabetes. Diabetic individuals have high triglycerides. So people who have propensity to metabolic diseases have high triglycerides. So ApoB very clearly correlates with high levels of triglycerides. Look at the difference between India and United States. And similarly, HDL cholesterol, which is protective, is also lower in Indians. So we can actually weave in a hypothesis and come up with a new idea, and this is one of the papers we have been discussing. So is the Indian phenotype conditioned by fetal programming, genetic and epigenetic and evolutionary changes like a loaded gun? So it appears to be. And so what are the triggers that are needed to fire this? This is where the holistic context comes in. So here we look at diet, food and food systems. This is the salt intake amongst people in Delhi and Haryana and Andhra Pradesh. It's somewhat higher. It's not very high, but somewhat higher. But look at the carbohydrate intake. Huge consumption of carbohydrates as compared to any other population. In fact, if you look at the intake of cereals, it's almost 68%. 2/3 of our food is cereals, and only 32% of which proteins are extremely low, and proteins are very important for protecting against diabetes. So on the background of a genetic risk or whatever risk that you may have, our diet is bad, clearly. Second is, this is the same thing. It says carbs still account for a large proportion of total energy intake. In addition to that, we are consuming more processed food, salted snacks and prepared sweets. Higher consumption of edible oils have been shown, and animal products. And the conventional oil, like in the north, the conventional oil used to be the mustard oil, and in south it's groundnut oil or gingerly oil, which is, and coconut oil. These have been replaced with palm and soya bean oil. One might think that these oils are good, but they have a higher proportion of polyunsaturated fatty acids, which when heated can get converted to trans fats, which are highly atherogenic. And in terms of trans fat, this is again a study from Delhi, which looks at what the trans fat content is. It's mostly the vanaspati, and you can see the protective oils of the coconut, olive oil, groundnut oil. So you don't have to consume groundnut oil, olive oil, groundnut and sesame oil are good enough. Then we look at vegetarianism and diabetes. Look at the United States vegetarianism and diabetes. Vegetarianism is quite protective. The problem with Indian vegetarianism is we beat the nutrient content of the vegetables to death by boiling it. This is a study by one of my fellows. So she said more starchy vegetables, highly cooked, lower legumes, very low dairy. So nutrient content, the other problem is nutrient content is lower in the fruits which are grown in water depleted areas, and as you all know, nearly 2/3 of the groundwater has got depleted in India. So there is an environmental dimension to this. Then the third dimension is urban design and urban health. So these are where our cohorts are located. We have geocoded them, and we looked at the physical activity in Delhi, and you can see in this particular cohort physical activity is low, but the same cohort has high blood glucose levels. And you can see there is no greenery, highly clustered houses, very close to a highway. There are no, people cannot walk. So lots of issues. The second thing is, you might say that Delhi is a good place which has got a lot of parks. So we looked at the presence of a park and association with depression. We are also writing a paper on hypertension and diabetes. If you are closer to a bigger park, the risk is low. So you might say, no, these are the rich people who are living closer to the park, and hence they may be having healthy habits. But we adjusted for all those factors, and despite those adjustments, bigger parks are important. Why? If you have smaller parks, they either become used for criminal activities or are taken away by the rich. The gated communities take them away. So bigger parks appear to be protective. So these are important information for the government when they look at uh, urban health and smart cities program. This again shows the effect of noise pollution on hypertension. The bigger dots means high traffic density and high level of blood pressure. This is the map of Delhi. Areas which has low traffic density, the blood pressure levels are lower. So these need further exploration. I mean, this is a very preliminary data, but requires further exploration. Then there are some emerging areas which we need to look at. One is air pollution and endocrine disruption, the development of coronary artery disease. And then we have this periodic dangerous levels, particularly during Diwali in Delhi. We have very high levels. The level that is recommended by WHO is 10 microgram per cubic millimeter area, whereas the Indian government says 10 is too low, we'll keep it at 40. On an average in Delhi, it's 100. During Diwali, it is 1,200, 1,500 in that range. So it can kill people with, who have heart disease or who have heart failure already. Then the role of pesticides and role of shared environment. How does shared environment influence diabetes or coronary artery disease? That has not been well studied, because most of the time we said it is the shared genetics, but I think it's possibly shared environment too. This is an example of our tracking of air pollution in Delhi on Diwali day. You see the pre-Diwali day, it starts very high, it starts at 250, but look at the Diwali night, it goes up to 2000. So again, you require some policy measures to reduce adverse outcomes for people. So we are programmed individuals, either because of fetal programming, genetic or epigenetic changes, and early life determinants. In the face of environmental triggers, we could develop coronary artery disease, or we could develop intermediate phenotype with the metabolic abnormalities such as diabetes or metabolic syndrome or others, and go on to develop coronary artery disease. Once we develop coronary artery disease, our background biology, personal beliefs, the affordability of drugs, air pollution and other issues, and the health system response can actually determine what we die of. So clearly it is much more complex than what we think. We start off with a very, very fundamental deep down hypothesis, and then broaden our horizon and think at all the factors that could increase mortality. So what is really needed? I think we require, we have always been talking about risk factors, and that we call as etiological or degenerative or adult life model. This is what Framingham Heart Study has taught us, this is what other studies have taught us. Barker and others have been talking about early life or developmental model. So what we need to think of is a life course model. So cardiovascular disease prevention starts during infancy and ends when the person dies. So it is a life course approach, that is what is needed. So while we know some mechanisms, how should we approach CVD prevention in a holistic context? So we need to identify low cost solutions, technological innovations, policy interventions, and capacity building. So we have been working in this area of task shifting, where we shift some of the tasks of cardiologists to physicians, physicians to family physicians or MBBS practitioners, and from them down to nurses and community health workers, supporting them with electronic decision support system and quality improvement along with several others. And several studies have been conducted all over India. And so the components of these studies are electronic decision support system, integrated care, quality improvement program, and a team-based care. And these are some of the electronic decision support systems which we have developed. It can give individualized patient information, like you feed the patient information, it will give an individual advice. Suppose a patient walks in, is 50-year-old, has a blood pressure of 160/100. The electronic decision support system will give an output saying this is the treatment that would be required for this patient. And this has been tested against experts and found to be equal. So it actually provides personalized advice. So we tested this in Himachal Pradesh, and using this Empower, what we call that Empower Heart features. It has several of these functionalities. We tested this, and this is one of the outputs. Like this is the third visit of the patient, so it gives a longitudinal output. It says the patient has stopped insulin, so maybe insulin requires to be increased. But the doctor says, it says the blood sugar is under poor control, so insulin needs to be increased, but the doctor says patient has stopped insulin, so I am not going to increase it. Whereas for the BP, it says we continue with the existing regimen. For lipids, it says it's still not under good control. So this actually spares the doctors almost 8 to 10 minutes of their time, as well as improves, it gives them that cue as to what treatment needs to be given, but as well as gives them flexibility. And we tested this over a period of 21 months. At 3 months, the systolic blood pressure fell by around 15 millimeters, diastolic by 7, and it continued for 18 months. So this has been scaled up in the states of Tripura and Mizoram, and actually has been very helpful in management of hypertension. So we have extended this to African continent, where we are introducing this in Rwanda. We are negotiating with several African countries, the Pan-African Society of Cardiology, and in Kazakhstan. It also provides data for big data, and it provides community to health system linkage. So this is one example of holistic context. And we are trying to change the healthcare model, and this is being done in a district in Punjab, where we put together all our experiences and trying to connect private and public sector and change the health system. Last is, you have to involve policymakers if you have to make a change. But the policymakers are bombarded with multiple messages. So we need to synthesize that correctly and package that correctly, take out the jargon and give it to them. And we have been very active in that area. We recently edited this cardiovascular, respiratory and related disorders volume, which provides advice to various governments across the world in terms of where to invest their money for treatment. And last is capacity building. And I think it's extremely important because we have very limited research capacity in this country. I mean, you may have a lot, but if you look at other parts of the country, it's extremely low. And I think we need to build that research capacity either through an immersion program, through a postdoc program, through PhDs. And that's where we are trying to build this collaboration, build large platforms so that people can use that for their research. And you can see it is a multidisciplinary team. This guy works in the area of cohorts. She works in the area of health economics. She works in the area of nutritional epidemiology. This guy works in clinical research. She worked on a new concept called syndemics. So you require to build that multidisciplinary team, and that's what we have been trying to do. And we also have colleagues from the United States who actually use our database. They work with us and have produced several important papers and new concepts, like this guy has become a global leader in cardiovascular diseases. So we also are giving back something to the US, so it's a bidirectional benefit that we have. I'll skip all this. Last point I wanted to make is there are several new frontiers and innovations that we need to work on. We need to move from individual to family or group level interventions and use new approaches. We need to develop new modeling techniques. We need to develop and evaluate new metrics of measurement. For example, dietary measurements are very, very poor. We use food frequency questionnaire and 24-hour dietary recalls. These are very poor correlation to actually what is eaten. So we need new metrics of measurement. We need to use technology for addressing many of the challenges, and we need to address some of the major challenges that we are facing, particularly air pollution, food systems, and the environment. Like we did an analysis, and actually you can also look at your own cohort and do this analysis. It's very important because what we now observe is there is a concordance amongst chronic condition. If you have dementia in the family, you may have somebody with a stroke or somebody with diabetes in the family. So there can be a common set of interventions which can be helpful. In terms of technological innovations, we are looking at improving the surveillance system using smartphones and smartwatches and wearable devices for surveillance, using GIS for community hotspots for chronic diseases. We need to improve diagnostics using point-of-care devices, improve drugs using fixed-dose combinations, improve drug availability and distribution, because that's another problem in most of our government settings, and improving access by providing virtual polyclinics to patients and integrating care of chronic diseases with communicable diseases and other diseases. This is from Bangalore. This is a simple device which has been developed by one of our colleagues. This is very inexpensive. It costs around 2,000 rupees. But it can do all these tests, and you can get it onto your mobile phone, and you can it comes into your database immediately. So it can be, you can see how easily it is done, and you get the data here, and it can be used by several people. So if you have to address, you work here, etiology, burdens, and laboratory. We work in this area, but I think we need to expand if we have to control cardiovascular diseases in the country. So we need to work through the epidemiology, and we need to work through translational sciences, improving access to care, improving availability, making distribution equitable, and doing a whole range of policy interventions. So for that, we need to get out of our comfort zones. I was a clinician, so I got out of it and got into research. So to me, cardiovascular disease research and global health research have been fun-filled challenges, but very satisfying. To me, the most satisfying things were establishing cohorts and a biorepository for future research, scaling up low-cost solutions, building a cadre of independent researchers, synthesizing and disseminating information, and building large-scale collaborations. So I would like to thank in French, but use the word mercy from all those whom I have missed, because there are lots of collaborators and I haven't named them, and I thank my family. Thank you. Oh, of course, my extended family.
Because then your whole beta cell thing could be validated so beautifully.
The problem with postmortem is Indians don't agree to provide autopsies, very few. Actually, and you're required to work in a hospital. We should try, it's a good thing. But there's a study which we are undertaking, which is looking at beta cell function in infants. So infants at 6 months, the mothers are given a OGTT during pregnancy, and their insulin resistance and insulin function is assessed. And when the kid is born, at 6 months, we do a OGTT of the kid and look at the beta cell function. So this is going to be the earliest evidence for beta cell dysfunction linking to the mother's insulin resistance. But your point is very well taken. I think we should do.
Yes, sure. Because they have all the biochemistry done. They have 3,000 volunteers who have come forward for they have a kind of a lab for their surgery. Because that would complete the story of them. Questions?
Sir, you talked about maternal, the environment from the child. What about before that? The maternal nutrition, the health of the mother itself, because we know things can go till 3 generations through other mechanisms. So how do you play that role in for cardiovascular disorders?
No, if I understand the question, maternal nutrition is very important. So are we talking about pre-pregnancy nutrition or nutrition during
pre-pregnancies?
Yeah, there are cohorts which are looking at that. These are called preconception cohorts. So there's one in Hyderabad run by an organization called SHARE in collaboration with the University of Pittsburgh. So they recruit children between the ages of 15 years and follow them up till they get married. And so they get the samples of both the fathers and as well as the mother and the kid. It's a very powerful cohort. They've recruited around 2,000 kids so far, and they're following them up. So we'll get the answer. But the fact is that there have been examples of what happens preconceptionally. If there's a folate deficiency, neurochondral defects are very well known. So that's the reason for giving folate. But similarly, we have to look at some of these issues in a preconceptual manner. The role of father has not been very well delineated, so that cohort will explain as to what the role of the father could be. So the point is very well taken, but these are very early days for that kind of research. Yeah. We don't know, that's what we think, but because if you look at the pattern of heart attacks, we have a completed thrombus as compared to the American population. If you look at the ST elevation myocardial infarction means a completed thrombus. A non-ST elevation myocardial infarction means that the thrombus was there, it's opened up and partially closed, that kind of a thing. 2/3 of our heart attacks are completed thrombus, whereas in the West it's the other way around. So one reason could be, it could be related to smoking, because we have a lot of younger people who die because of that. So one explanation is smoking, and smoking increases the thrombotic milieu. The second is the infections. We have not studied the relationship between infections and myocardial infarction very well. Infections can increase your thrombotic milieu and inflammation, of course. The answer is not clearly known. But the fact is that we have very high proportion of ST elevation absorption.
The reason I asked that question was that I am actually personally affected by this. That without any other risk factors, I found that factor V Leiden was, there was a anomaly in that. And again, factor 2 and factor 8 also there were some anomalies. And people said, okay, that you don't have any other risk factor, but these are actually the clotting, the thrombotic disorders are responsible for the heart attack. And so is there anything that Indians are more prone to such diseases?
We don't have data on that, but what you're talking is a very specific anomaly of factor V Leiden deficiency. It's been shown in the cohort in the United Kingdom called the Northwick Park study, where they showed that factor V Leiden is indeed associated with higher thrombotic potential, but that has not been explored in Indians.
Any more questions? No. So let us thank Professor Prabhakaran for that wonderful lecture. And I would request Dr. Ganesh Chauhan to give him a memento from us.
Thank you. I will keep it like this. Okay, thank you.
So please join us for tea outside. Thank you.